Sepsis Bundle Treatment. Time is Tissue. By Alex Schrick
and Christine Yartzoff.
So, what is sepsis?
Sepsis is a life-threatening complication of infection. It causes overwhelming inflammation over the entire body.
Oh wow, so who is at risk for sepsis?
ICU patients with weakened immune systems, infants, children, and the elderly are most vulnerable.
What is the impact of sepsis?
Sepsis affects approximately 750,000 Americans every year. 28 to 50% of these people die, more than prostate cancer, breast cancer, and AIDS combined. Treatment involves a prolonged stay in the ICU and complex therapies, costing the U.S. $17 billion in medical bills.
Well, why should we care about sepsis?
Sepsis is a rapid killer, affecting millions of people worldwide. The mortality rate for sepsis is approximately 1 in 4, or 25%.
That's a lot. How can we prevent sepsis?
The Surviving Sepsis campaign and the Institute for Healthcare Improvement published international evidence-based guidelines, including a sepsis bundle. The bundle was initially published in 2003 and was updated in 2008.
What about now?
In 2013, the bundle was divided into 2 bundles, a 3-hour bundle and a 6-hour bundle, with the goal of 25% reduction in sepsis mortality rate.
How can sepsis progress to multiple organ dysfunction syndrome, or MODS?
Well, it begins with infection, which can progress to systemic inflammatory response syndrome, or SIRS, which can progress to sepsis, which, as we explained earlier, is inflammation over the entire body, and that can worsen and progress into severe sepsis. If untreated, severe sepsis can progress to septic shock and ultimately MODS, or multiple organ dysfunction syndrome.
So for our scenario, a student nurse, Christine, is caring for a patient during her immersion in the ICU. A patient suddenly takes a turn for the worse, and the student nurse immediately alerts her preceptor nurse, Alex. The preceptor nurse assesses the patient and recognizes the clinical presentation of sepsis.
Alex, what should we do?
Well, we should alert the physician and implement the Surviving Sepsis campaign bundle.
I'm not familiar with that bundle. How many bundles are there?
Well, there are 2 bundles, a 3-hour bundle and a 6-hour bundle. Each bundle contains items that must be completed within that time frame.
Oh, okay, that makes sense. So what are the components of the 3-hour bundle?
Well, the 3-hour bundle has 4 components. First, we must measure the patient's lactate level.
Okay.
Second, we obtain a blood culture before administering the prescribed antibiotics. Third, we actually administer the prescribed broad-spectrum antibiotics. And fourth, we administer the prescribed 30 ml per kilogram crystalloid IV fluid for hypotension or for lactate level of greater than or equal to 4.
So why do we measure the patient's lactate level?
When the oxygen level in the body is normal, carbohydrate breaks down into water and carbon dioxide. When the oxygen level is low, carbohydrate breaks down for energy and makes lactic acid.
Okay.
Lactate is a marker for cellular hypoxia. A level above 4.0 millimoles per liter is associated with a 27% mortality rate.
Wow.
Compared with a mortality rate of 7% for patients with a lactate level of 2.5 to 4.0 millimoles per liter, and a death rate below 5% for those with a lactate level below 2.5 millimoles per liter. So obviously we want to keep it down as much as possible. Right. Lactic acid levels get higher with strenuous exercise or other conditions. So like when you're working out and you get a sore muscle, and other conditions could include sepsis and shock, which is in this situation.
Right.
Which actually lowers the flow of blood and oxygen throughout the body. So ultimately, this is the way that we can see how much oxygen is reaching the tissues in the body.
Okay. Wow, Alex, you're so knowledgeable. So why do we obtain a blood culture before administering antibiotics?
Well, only 30 to 50% of patients with sepsis have positive blood culture results. So blood culture results do not need to be positive. While SIRS, sepsis, and septic shock are associated commonly with bacterial infection, bacteria may not even be present. So collecting blood cultures prior to antibiotic administration offers the best hope of identifying the organism that caused the severe sepsis in an individual patient. But failure to check the blood cultures prior to antibiotic infusion will actually perhaps affect the growth of any bloodborne bacteria and prevent a culture from becoming positive later.
Wow. So then why do we administer the crystalloid IV fluid for hypotension or lactate level 4 or greater?
Patients with severe sepsis and septic shock may experience ineffective arterial circulation due to vasodilation associated with the infection or impaired cardiac output. Poorly perfused tissue beds result in global tissue hypoxia, which is often found in association with an elevated serum lactate level, like we were talking about earlier. So serum lactate value greater than 4 is correlated with increased severity of illness and poorer outcomes, even if hypotension is not yet present. As such, patients who are hypotensive or have a lactate greater than 4 require IV fluids to expand their circulating volume and effectively restore perfusion pressure. As the volume of distribution is much larger for crystalloids than for colloids, which is the other alternative for IV fluids, resuscitation with crystalloids requires more fluid to achieve the same goal and results in more edema. So the guideline says to use crystalloids.
Okay, so that all makes sense. So then what about the 6-hour bundle?
Well, the 6-hour bundle has 3 components that must be done within 6 hours.
Okay.
So first, we apply the prescribed vasopressors for refractory hypertension. Second, we measure the CVP, which is the central venous pressure, and the SCVO2 for persistent refractory hypotension, or if the patient's initial lactate level is greater than or equal to 4. Third, we must remeasure the patient's lactate level if the initial level was elevated.
I'm confused. What does refractory hypotension mean, and why do we measure CVP and SVO2?
That's a good question. So, new septic shock is defined as severe sepsis associated with refractory hypotension, which is a blood pressure of less than 90/60, despite adequate fluid resuscitation and or a serum lactate level of greater than or equal to 4 millimoles per liter, like we talked about. So refractory hypotension is thought to have a normal blood volume, but in whom adequate circulation cannot be maintained. So low blood pressure that does not respond to treatment, essentially.
Okay, non-responsive's the key term there.
Right, so if you're administering fluids, you would assume the blood pressure would go up because, you know, there's more fluid in the vein.
Right.
But unfortunately, it does not increase the blood pressure. So that's why it's called refractory versus normal hypotension.
Okay. What about the CVP then?
So regarding CVP, the goal is to increase the central venous pressure to greater than or equal to 8 millimeters mercury within 6 hours in 100% of indicated cases.
Okay.
We target the central venous pressure to be between 8 and 12. Further, the goal is to target CVP to be 8 to 12 millimeters of mercury in the superior vena cava oxygen saturation, which, like you had asked, is this SCVO2 of 70%, which is mixed venous oxygen saturation, or SVO2 of 65%.
Okay.
So we just want to make sure that the tissues are being perfused and that enough oxygen is getting out to the body, if that makes sense.
Wow, not everything makes sense. Thank you, Alex.
You're very welcome, Christine. Now, here's a fact sheet to help you remember the 2 surviving sepsis campaign bundles. Now let's go save our patient.